The third analog we are wanting to hear about is the use of human growth hormone in children. And the speaker to that example is Lainie Friedman Ross, who is the Carolyn and Matthew Bucksbaum Professor of Clinical Medical Ethics at the University of Chicago, where she's also professor in the departments of pediatrics, medicine, surgery, and the college. Thank you for being here, Lainie.
This on?
Yeah.
Okay, thank you. And thank you for inviting me. I had a hard time when I was first asked, I said yes, and then I had a hard time figuring out what I was supposed to say with growth hormone therapy as a policy analog. So my slides may be about 4 hours behind where I think I'm thinking about these issues today. Let's see. So the topics that I was asked to address was the evolution of the clinical application of human growth hormone in children, thinking about issues such as slippery slope, therapy and enhancement distinction, the balancing of risks, benefits, and uncertainties of using human growth hormone in a traditionally protected population, and finally, the issue of fairness, equity, and access in treating some small children with human growth hormone. So just a really brief history of human growth hormone through 1985. The importance of the pituitary gland for growth was actually recognized in the late 19th century. Although many hormones were made from animals, like insulin, it turned out that growth hormones from animals didn't work. And so human growth hormone, pituitary human growth hormone, was actually made from human pituitary glands beginning in the late 1950s. And in 1963, the National Pituitary Agency began to collect and distribute pituitaries in a logical and sensible manner. They, at least that's how they described what they were doing. They were funded by the Department of HEW, now the Department of HHS. And from 1963 to 1985, the NHPP sent pituitary human growth hormone to hundreds of doctors throughout the U.S., and approximately 7,700 children were treated. In 1985, 3 young men treated with pituitary human growth hormone died of Creutzfeldt-Jakob disease, a neurodegenerative disorder, and it was realized that it could be brought back to the pituitary glands that had been made. And HHS immediately stopped the distribution of the hormone. And an update, just 29 individuals, all of whom had received treatment prior to 1977, the year that the NHPP actually changed the way that they were developing it and added a new purification step, eventually were diagnosed with Jakob-Creutzfeldt and died of that. Of note, this is actually much lower than the number who experienced this devastating condition in France and in the UK, where fewer people had actually been treated. In 1985, and a few months after human growth hormone was removed from the market, the FDA actually gave approval for recombinant human growth hormone. And so that really took away the huge issue was there just wasn't enough human pituitaries to make lots of it. But now all of a sudden, as we can do it with recombinant, the amount is as much as we need. And now all of a sudden the issue is became of expanding the usage and no longer thinking whether it just had to be given for people who had pituitary growth hormone deficiency, but possibly also to be used, for example, for children who are short for other reasons. And this made for the potential for a huge market, as you'll see on this slide. So one question here is whether this is expanding indications or a slippery slope. So in 1985, the year FDA approved recombinant human growth hormone for growth hormone deficiency. As you can see, in 1993, it was expanded to those with chronic renal insufficiency and then Turner syndrome. Interestingly, in 1997, all of a sudden, we're starting to use it for adult growth hormone deficiency. So this is one of the few times where you actually hear about treatment actually starting in pediatrics and then expanding into adults. What's also important is the reason to start using it in adults is because we came to realize that growth hormone deficiency wasn't just about not growing, but that in adults there were other psychological and other physiological reasons why you might need treatment. So what the question of growth hormone as a therapy or enhancement is actually, there was a case study published by David Allen and Norm Faust, and they talked about 2 little boys, and you'll often hear the story of growth hormone deficiency about boys because it seems that, and this gets to the whole therapy versus enhancement debate, being short is a more of a problem. Whether it's a disease we'll have to think about, but is more of a problem in boys than it is in girls. But here was the case of Johnny as a short 11-year-old boy with documented growth hormone deficiency resulting from the treatment of a brain tumor. His parents are of average height. His predicted adult height without growth hormone is now 5'3", and with growth hormone, had he not had the brain tumor, he was expected to be 5'10". Billy is a short 11-year-old boy with normal growth hormone secretion according to current testing methods. However, his parents are extremely short, and he has a predicted adult height of 5'3". And so Alan and Faust asked, should we treat Johnny, should we treat Billy? And they answered that both have a disease, and they declared short stature as the disease, that it was no longer that Johnny had the disease of growth hormone deficiency, both were short. And they argued then that since the disease is short stature and not growth hormone deficiency, they both should have an equal claim. And they argued it should be a right and not a privilege, which meant that once you decide that short stature is a disorder, then everybody deserves an equal access. They rejected the enhancement treatment distinction, and they said, and here's what they wrote: if clinical trials show efficacy in non-growth hormone deficient children, there would be no coherent ethical basis for defining access by growth hormone deficiency. Rather, growth hormone responsiveness should be the central criterion in considering candidates for treatment. Whatever percentile is considered tall enough for growth hormone deficient children should also apply to non-growth hormone deficient short children. And basically they said, so you should treat only if being short is a serious handicap. And interestingly, they wouldn't have actually treated either Johnny or Billy because they were actually above the first percentile for height, and they defined the disease of short stature as being below the first percentile. So in summary then, it really wasn't about whether you are or not growth hormone deficient, but if you have a disease, short stature, and whether you think that the treatment will actually work. So there were a lot of critiques about this, asking the question whether the disease was growth hormone deficiency or whether the disease was short stature. And one reason to say that there's a difference and that the disease really was growth hormone deficiency was, as pointed out, for the reason for expanding growth hormone therapy to adults was that there are other negative consequences of being growth hormone deficient, particularly with regard to behavioral issues. And in contrast with familial growth hormone, while growth hormone could add 1 to 2 inches, there were actually not the psychological benefits of the additional height, which is one of the arguments to calling it a disease, was that particularly short men had psychological problems because of their shortness. But what they found was whether or not they have psychological problems for being short, being told that you have a disease that needs treatment with 6 shots a week for the next 6 years might have caused as many psychological problems as they were hoping to fix. And given that it turned out that growth hormone in non-growth hormone deficient children only led to about a 1 to 2 inch height benefit, these young boys were still relatively short and so didn't get any of the psychological benefit. Nevertheless, many of the critiques also argue, though, that Allen and Faust are right to consider the equity question. If we allow parents to buy this without insurance, there's pressure to expand reimbursement in order that everyone has the same access, and we don't create, whether it's higher socioeconomic individuals getting better genes or getting better height. So what begins as a consumer issue becomes an issue of fairness. And I would argue that that critique works if it is a treatment, less so if it's merely an enhancement. One of the most important articles about the whole growth hormone debate actually was published in 2001 by Alan Buchanan, and he brought in this concept of expansive biotechnologies. And I'm quoting from him: growth hormone can be seen as a paradigm of expansive technologies that begin as clear medical treatments and then are found to offer benefits that do not clearly belong in the healthcare system. So again, getting to the question of whether this is a disease or an enhancement. Although treatment for pituitary dwarfism, or what we now call growth hormone deficiency, is clearly within the appropriate goals of medicine, newer uses of growth hormone to produce marginal gains in height or to slow the aging process are less clearly appropriate uses of healthcare. So for Buchanan, this was important because, first, growth hormone deficiency fits within the medical paradigm. Then there's the concern about equity and access issues. But if you're using growth hormone to treat just merely short stature, we must ask whether to prescribe its availability or to permit it as an elective procedure, acknowledging the potential inequities that this, quote, enhancement may cause. And he concluded by saying, even if a burgeoning market in biotechnology enhancements does not have an adverse effect on equal opportunity, it might erode society already shaky commitment to the right to an adequate level of care for all. Scientific talent and resources might be drained away. So not only was he concerned about the misuse of the drug, but the whole approach to worrying about these type of health care means that we're not talking about more important health care for individuals both here and abroad. I think that I gave the history up to 1985. We then get recombinant human growth hormone, and then we're into the history of growth hormone after 2010. And what the most important thing to know about after 2010, since my time is coming to a close, is that we actually had longitudinal observational data. And we had this data, and it only lasted until 2010, and then they stopped collecting data because they felt they had enough long-term data. Interestingly, internationally, the database still persists. And why does it matter? And it matters a great deal when you're talking about children, because whether there are health benefits or risks in the first 5 to 10 years is important, but it's also going to be important for the next 50 to 60 years. So an important analog for what we're talking about. And here, and obviously you'll have access to the slides, you can see all the risks and benefits that are now known about growth hormone and the treatment of it in non-growth hormone deficient children. So finally, the last question, and I've run out of time, so I'll just hit on it, is to ask the question of the long-term benefits and risks, is to really ask, is this treatment or is growth hormone in the best interest of the child, particularly given the uncertainties of the long-term risks not being known. And finally, an interesting critique of this whole debate was, while parents may rear their children as they choose, they cannot insist that the medical profession cooperate with whatever plans they have. And this just raises the whole issue of whether this, all of the issues that we're talking about today really should be medicalized. Going to and the last issues that I'll cover, and I'll end with this slide, is just thinking about the issues of both access and consent. If growth hormone is a treatment and the benefits truly outweigh the risks, then justice would require that all have access. And this would be not just for growth hormone deficient short children, but also for children with certain genetic conditions like Prader-Willi. But if in some populations the benefits only modestly outweigh the risk, there might not be a moral access to access, and that would be the non-growth hormone deficient short but otherwise healthy children. Whether it should be permitted as an enhancement then raises questions of having insurance coverage for it. And finally, we do have to acknowledge that with this issue, we have the issues of parents giving consent, but as the child ages up, because often growth hormone therapy continues through adolescence, what are the limits of parental autonomy and what role should the child have? And those answers might differ depending on whether we consider growth hormone a treatment, an enhancement, or whether we think it's truly dangerous. So Thanks. I'll stop here given the time.
Great.